IVF is in vitro fertilization. So this means that we're going to be fertilizing eggs and sperm together in the lab. When we do this, we've got to get the eggs and sperm out of the body. That sounds really straightforward, but the truth is success is all in the numbers. The age that you are when you go through IVF and the number of eggs that you can get will dictate a lot of your success in a per cycle basis. But this doesn't mean that other factors are not important, and it doesn't mean that you can't have success if you are older or if you have a lower egg count. Welcome back to the As a Woman podcast. I'm Dr. Natalie Crawford, and today we're talking about a topic that so many people have questions about, but often feel too overwhelmed to ask: IVF. Whether you're considering it, preparing for it, or just want to understand what this process actually looks like, this episode is for you. Because while IVF is one of the most powerful tools in fertility medicine, it is also filled with the unknown: timelines, hormones, expectations, and emotions. This can all be hard to navigate. But in this episode, we're going to walk through what IVF actually is and who it's for, what makes it emotionally and physically complex, and how to prepare, ask the right questions, and advocate for yourself every step of the way. If you're trying to conceive and wondering what options are ahead, this is the clarity that you've been looking for. So let's dive right in. In the first part of this episode, we're going to talk through the education about the IVF process, what it really is, and what to expect. Who needs IVF is always one of the first questions, and the truth is we often don't know. But one thing I tell my patients is that I'm a big believer that you don't have to fail at lesser aggressive or effective treatment before you can get to IVF. There are circumstances where IVF may be the only thing that makes sense for you, or it might be one option that you're presented along with some others. The ultimate decision to do or not do IVF should be yours alone. But one thing I hate personally is when patients come right out the bat and they say, I don't believe in IVF, or I'm not going to do IVF, before they've learned about the process. You owe it to yourself to learn about what IVF is before you decide to reject it or accept it. So that's what we're going to do today. Break down what it is so that you can make an informed decision based on the actual science and facts from a real expert and not just what you might be hearing on the internet. In a nutshell, IVF is in vitro fertilization. So this means that we're going to be fertilizing eggs and sperm together in the lab. When we do this, we've got to get the eggs and sperm out of the body. When we do IVF, that sounds really straightforward. But the truth is success is all in the numbers. The age that you are when you go through IVF and the number of eggs that you can get will dictate a lot of your success in a per cycle basis. But this doesn't mean that other factors are not important, and it doesn't mean that you can't have success if you are older or if you have a lower egg count. But it's all about setting appropriate expectations so you know what is going to be your journey. I always say, are you running a 5K or is this a marathon? You're going to mentally and emotionally prepare differently for those two things, and that's what we're trying to do here. When it comes to IVF, before you get started on the process, we want to make sure that we've tested your ovarian reserve. Again, ovarian reserve is how many eggs that you have available in a given month. I always like to say this is the group of eggs that's been sent out of that vault in 1 month. Now, when we're not doing IVF, one of these eggs will be stimulated to grow and ovulate, and the rest of them will die. But when we do IVF, our goal is to get all of these eggs growing. That sounds really easy in concept, but in reality, your body doesn't want to have all these eggs to grow at one time. Humans are not meant to have litters of children. If you have 20 eggs outside your vault in 1 month, your body does not want to have 20 babies. This is why our own body has checks and balances to prevent this from happening. And in order to get this goal achieved of multiple eggs, we have to override that normal check and balance in the hormone system to get the eggs to grow. And this is what we know as the IVF protocol. I like to think about the IVF protocol as a suppression and then a stimulation. And the way I like to explain this is we can think about a nest of baby birds. Let's imagine that ovulation is mommy bird bringing in one worm. That worm is FSH, which is the hormone from the brain that gets one egg to grow. Well, you've heard it before that the biggest bird gets the worm, and so that bird's going to push all the small birds out of the way, eat the worm, and grow to be the biggest. And this is what's happening inside our body month to month with natural ovulation. If I starve all the birds first, and there's no worms coming in, well, what's going to happen is that all the birds are going to be really small and hungry. There is no big bird. We can then come in and bring a bucket of worms every single day, And there's enough worms for all the birds, and they're going to eat at the same pace and grow together and all get to that same size. So this is the idea of what we're trying to achieve. I'm going to suppress FSH release from the brain, and then I'm going to stimulate and give more FSH than your brain would normally make so that we can get all of those eggs to grow. And that is why you have to take hormone shots when it comes to IVF. The stimulation part is pretty similar in a lot of patients, meaning the bulk of the medication that we're giving you is FSH. Depending on your protocol, your age, your medical situation, your AMH, you're going to be on different doses, and you might be on additional medications like an LH-FSH combination, human growth hormone, or even Clomid or letrozole can be utilized as stimulation medications. But preceding this, you might have a suppression. Sometimes patients are given a spontaneous start protocol, and this means that you are just starting with your period, which is a naturally suppressed phase for younger women. But if you're older, this is often not the best protocol for you because your body starts to send out stronger signals of FSH as your egg count gets lower. And what we don't want to have is that big bird already growing. So anything that is a suppressant trying to prevent FSH release is going to be a hormone that either blocks or modulates FSH. So these are things like estrogen, progesterone, even testosterone. We have ovulation blockers, we have blockers that work in the brain, and we have combinations of these medications. And a really common option is actually the birth control pill. Cheap, easy, and effective. Your situation might be different, but usually you will lead in with some suppressant medication for about 2 to 4 weeks, and then you'll come in for a baseline ultrasound. At the baseline ultrasound, what we're going to be doing is looking to make sure that there's no big bird. Essentially, we want your follicles all really small and ready to grow. I often call this quiet. The ovaries are quiet. There's no large follicle. If everything looks good at the baseline, you're then going to be able to start the stimulation. And the stimulation is always hormone shots. So this is what people think about when they think about IVF or egg freezing. These shots are subcutaneous injections, meaning it's a tiny needle, like a diabetic who gives insulin. They usually go in your stomach area, and you'll be giving them to yourself in most situations every day for about a 2-week process. That's the length of time that it takes to grow the eggs from small to maturity. During this timeline of the stimulation, you're going to be coming in for monitoring appointments. Now, monitoring is typically every 2 to 3 days, and this is going to consist of an ultrasound so that we can look at the follicles, count how many are growing, and we're going to measure them using the ultrasound to get the mean diameter in millimeters. As the follicles get bigger, the eggs inside are getting more mature. The eggs are also making estrogen, so we also like to check estrogen blood levels to see if we need to make any changes to the medications. When the eggs get to maturity, we're then going to set up for the egg retrieval. And the egg retrieval is a process that is done under anesthesia. So in our clinic, what will happen is you'll come in, you'll get an IV, you will go to sleep. It's about a 20-minute procedure. So it's twilight anesthesia where you don't have a breathing tube or anything scary. But what we do is we attach a needle to the vaginal ultrasound, and then we're going to go in vaginally while we put the needle into each egg. We'll drain each follicle, get follicular fluid in the egg, and then we pass those off to the lab so they can inspect all of the fluid to find the eggs. Once the eggs are identified, it's then going to be time for all of the fancy stuff that happens in the lab, which we'll cover that in just a second. It's important to understand that the protocol selection, in my opinion, is the art of IVF. That's the fun part, trying to find the perfect balance of suppressing you just enough so that I can get the best outcome and get all the eggs to grow, but not so much that I don't get any eggs to grow. Sometimes the protocol we choose is not perfect, and this is a good situation where it might make sense to cancel the cycle. I know that nobody wants to cancel a cycle. Your clinic doesn't want to cancel the cycle either. A canceled cycle for a clinic counts as a negative pregnancy test when it comes to IVF success rates. So it's not something that we do just because we want to, but we do it at our clinic because it's the best thing for you. If you are not achieving your full potential and we think you can do better, we often have a conversation to say, maybe this doesn't make sense and we should cancel this and try a different protocol or combination of medications to see if we can get a better outcome. This is honestly the nicest thing a clinic can do for you, and you'd be shocked how often I see that clinics don't do this. Patients have no idea how many eggs they have growing, if that's close to what their ovarian reserve says that it should be, and they just push through on a protocol to get to an egg retrieval with no information. Patients are then devastated to get so many fewer eggs than they were hoping for, and they had no explanation along the way. That's why it's really important to know your antral follicle count before you start the process. And even though your body's not perfect and we may not get the same number of eggs every single time, what we want to do is be getting close to that number. For example, if I count 16 eggs before we start the process, you're going through IVF and I only see 5 growing. That is so far off from what I think your potential is. We're going to have a discussion about canceling and starting over. If, however, you have 12 eggs, that's pretty close and could represent just a month-to-month variation. You'll also be surprised how often clinics just use the same protocol. Of course, if you have a ton of patients, it's going to be easier to just pound the same protocol on everybody. I'm a huge advocate for personalized medicine, especially when it comes to IVF, meaning your protocol should be carefully chosen for you and your clinical situation. The protocol is typically named for the suppressant type of medication, meaning one of the most common protocols is called an antagonist protocol. This is where we use what's known as an antagonist medication, or commonly called an ovulation blocker, to prevent you from prematurely ovulating. Your body will ovulate because of estrogen triggering the brain unless we prevent it in some way with IVF. So an antagonist protocol is our typical protocol for high responders. This can be started with a spontaneous start protocol, meaning off your period, you start the gonadotropins, and then as the follicles get bigger, we use the ovulation blocker. You can also lead into the antagonist protocol with either birth control pills or estrogen as a prime, depending on your situation. Another protocol that's commonly used includes Lupron. Now, Lupron is a really interesting medication. It works with the brain, and what it actually does is it binds in the pituitary gland and it tells it to send out all of the FSH and LH that it has. This means that it can be used at multiple different times in multiple different ways. It can be used as part of the stimulation, which is honestly not my favorite way to use it because the brain's amount of FSH and LH you have is probably much lower than the dose that I want to give you. But if we start when the pituitary gland has a low level of FSH or LH, typically either in the luteal phase of the cycle before or while you're on the birth control pill, we can keep FSH and LH low and suppressed, and that will prevent ovulation. Lupron has the added advantage of being really excellent for autoimmune conditions, endometriosis, and if patients have a lower egg count, I find that it usually gives that magic blend of not suppressing too much, but just enough. And then there's some other in-between protocols for unique situations. A very, very low egg count is one example, or somebody who's just not getting the response that you might want on their protocol. No matter the protocol that we choose, once the eggs get to maturity, you're then going to have what's called that trigger shot. And the trigger shot is typically HCG, or human chorionic gonadotropin. Yep, that's the same hormone that you test in a pregnancy test, but we can give it in an injectable form. And it binds to the same receptors as LH, and so it stimulates or it mimics that LH surge from the brain. This is because we don't have an isolated LH compound that we can actually give you. HCG is a really effective trigger. It's kind of the tried and true bread and butter option that we use. But in some patients, if you're on an antagonist protocol and you have a very high egg count, I'm looking at you, PCOS patients, using an HCG trigger might put you at risk for something called ovarian hyperstimulation syndrome, or OHSS. OHSS is when you have so many eggs that you're making so much estrogen that you can actually get quite sick. This estrogen at very, very high prolonged levels can cause the water component of your blood to leak out of your blood vessels. That leaves your blood really thick, predisposes you to blood clots, actually kidney damage, but also that fluid starts to get on your stomach and in your lungs. You can get hospitalized for weeks with really terrible infections. Because OHS is so severe, there's a few things that we do about it. One thing is we can use Lupron because it does send out all of that FSH and LH in the brain. We can use that as a trigger in some patients. We also will recommend what we call a freeze-all approach for embryos, meaning when we're doing an embryo transfer, we are waiting, letting your hormone levels normalize before we get you pregnant. And we also want to make sure that we are stimulating you in the appropriate way and using proper medications after the fact. So a freeze-all approach with a Lupron trigger might be something we're trying to do if you have a high egg count and we're worried about OHSS. Well, the magic of IVF all happens in the lab. We always think about what we have to do as patients, but let's go over what's happening in the lab. So up to this point, you have been on a suppressant for probably 2 to 4 weeks, and then it took about 2 weeks to get the eggs to grow to that mature level until you got to the egg retrieval. Well, on the day of the egg retrieval, we need a sperm sample from the lab, and then the sperm is going to be isolated and identified, and then fertilization is going to occur. I'm about to go over a bunch of numbers. And one thing I want to say is that these are averages. And by definition, average means some people do better and some people do worse. We don't know how you will do, but averages are going to guide us and set the road for expectation. When it comes to fertilization, there's 2 main options that you could use. One is considered conventional fertilization. And this is where I want you to imagine I've got a petri dish full of eggs and I just put sperm on top of it, cover it, and put it in the incubator and check on it the next day. That means that the sperm has to get into the eggs just like it would in nature. The other type of fertilization is called ICSI, or ICSI, which stands for intracytoplasmic sperm injection. This is where you actually look under the microscope, identify a normally shaped moving sperm, pull it up into a little pipette, and you inject it directly into each egg. This, of course, is going to be a more successful option for fertilization, and it's going to be recommended for male factor or anytime we could be concerned about sperm function. When you do ICSI, we see fertilization rates typically of about 75 to 80%. So we're about to go through all of the attrition because we know it's not a direct path from getting one egg to getting to the baby. Because we know that it's not a direct path, meaning not every egg is going to turn into an embryo or be able to be used and have a baby. If we have an average example, what we would see is, let's say you are 35 years old and we got 16 eggs, which would be a very average number. Of those, if we went and did ICSI for fertilization, now we would say 12 of them have fertilized. These embryos then have to grow into an implantation stage embryo called a blastocyst. This is a day 5 or 6 embryo. Did you know that fertilization typically happens in the fallopian tube and that embryo grows and develops across the course of the tube until it arrives in the uterus 5 or 6 days later? And that all has to happen in the IVF lab. So what we will do is watch the embryo while we keep it in the perfect culture conditions, the right temperature, the right pH with all the nutrients that it needs. But even despite that, we're going to lose about 50% of the fertilized eggs will not make it to the blastocyst stage. So that means if we had 16 eggs, 12 of them fertilized, we now have 6 embryos that have reached the blastocyst stage. Well, based on your age, not every embryo is going to be genetically normal. Not that you have to do genetic testing, but genetic testing exists so that we can test the embryos before we implant them in your body. This is called PGT, pre-implantation genetic testing. Now, PGT can be used for aneuploidy or age-related random chromosome abnormalities called PGTA, and this is the most common use. We are just checking the chromosomes. Are all the right chromosomes there? We do find out sex because sex chromosomes are a part of your normal chromosome complement. But unlike popular media would tell you, we are not testing for eye color or height or sports abilities. That does not exist right now with IVF technology. We are just trying to find out which embryos have all the chromosomes that they need to become a baby. There's also PGT testing for things like single gene disorders, such as cystic fibrosis, or for balanced translocations, which is a structural rearrangement of your chromosomes that can lead to miscarriage. This is called PGTM for a monogenetic or single gene disease, or PGT-SR for structural rearrangement. When you do PGT testing, what we're going to do is take about 5 to 8 cells from the placental portion of the embryo. The embryo at the day 5 or 6 blastocyst stage is divided already into the outer surface, which becomes the placenta, and then there's an inner cell mass, which will be the baby. So we take 5 to 8 cells from that outer surface or the placenta, and we send those off for testing. And then it typically takes about 2 weeks until we get genetic testing back. In that time frame, you're going to have a period, and then you'll be waiting for your results to make your next decision. Well, if you're 35, we're expecting about half of your eggs to be genetically normal. So this means if I send off 6 embryos in my example, I would expect 3 of them to come back genetically normal or euploid. I'm then going to be getting everything set up for an embryo transfer. What's really important here is to also understand that an embryo transfer is typically done with a frozen embryo in today's world. And this is called an FET, or frozen embryo transfer. This means I want you to think about IVF being one stage of the process and then an FET being the other stage. FET has protocols as well, meaning we can do a medicated or a controlled cycle. This is where I'm telling your body to grow the lining with estrogen. And then there's versions of a natural cycle, which is the concept that your body is ovulating while it makes its own estrogen as well. There are pros and cons to both of these that we will get into in more detail, but just knowing there's different protocols that should be chosen based on your unique situation. In either way, we've got to get to that correct implantation stage, which is about 6 days of progesterone exposure. So it's going to take typically at a minimum 3 or 4 weeks of some type of protocol before you're ready for the embryo transfer. And then after the embryo transfer, you still have to wait for that pregnancy test. You're not going to get away without a 2-week wait. So this entire process does take time. Success rates depend on if you do genetic testing and your age. So if you do genetic testing and you have genetically normal embryos, what we see is that with one genetically normal embryo, we're going to have a live birth rate of about 65%. However, cumulative rates become much better. So after 2 transfers of genetically normal embryos, we're going to have closer to an 86% chance of success. And after 3 genetically normal embryos, 95% of people would have success. So this means that one single embryo may not effectively become a baby, but if you have enough embryos, which is the big but, you can have a very high chance of having success, and IVF is successful for most people. So our patient who was 35, ended up with 3 genetically normal embryos, has a 95% chance that she'll have 1 baby from those. Note how that is not 3 babies. So if she wanted to have multiple children, this is going to be a scenario where we're going to want to do multiple rounds of IVF before you do an FET. Meaning I'm going to want to get this month's group of eggs, and then maybe I want to go and get next month's group of eggs so that I can have more embryos to complete your family goal, because it will only be harder to do this in the future. If she gets pregnant and then we're doing IVF again when she's 38, she's going to have fewer eggs available and more of them will be genetically abnormal. Let's say we only get 12 eggs at that time. And let's say that 10 of them fertilize and 5 of them grow out. Well, only a third of them are going to be normal. So she's going to get more usable embryos when she's 35 than when she's 38. Importantly though, she's still going to probably get embryos. So it's not that it's a no-go. It's just she's going to have to invest more time, money, and emotional and physical effort in order to get that outcome. Well, this brings me to our next part, which is how IVF really is if you're going through it. I had a patient who came in, they weren't getting pregnant, and when we did testing, we found out they were actually both carriers for the same genetic disease. They carried something called SMA, or spinal muscular atrophy, which is a disease that causes neuromuscular degeneration, much like Lou Gehrig's disease or ALS, but for kids. It can be devastating. And they talked to genetic counselors and decided they wanted to go through IVF and do PGT-M testing. This means that we were going to screen the embryos to see, number 1, do they have the right number of chromosomes, which is PGTA, and then number 2, they would also have an additional probe made for where they each carried this gene to see if the embryos had them. Well, if we were following basic science, what we should see based on genetics would be 25% of the embryos should be not carriers at all, have no copies of the gene, 25 should have both copies and be affected, and 50% should be carriers. When we think about this, we prioritize transferring non-carriers at all, but then we typically would transfer carriers because this is an autosomal recessive condition, meaning that you need 2 copies of the gene to be affected. Well, in their case, they had a lot of embryos in their first cycle. We sent off 10, but unlike what we would have expected, we had 6 come back fully affected with the disease, and we only had 4 that were either a usable carrier or a non-carrier state. We had 1 non-carrier and 3 that were carriers. Well, they really wanted a family of 4. They were younger. They were pretty shocked that 10 embryos only yielded them 4 usable embryos. And as we said earlier, if you listen to the math, that's probably not 4 children. So they actually had to go through IVF multiple times. This is a great example why preconception genetic carrier screening before you even start IVF is really important, because that's how they found out that they did carry this. And then having a good talk about your goals and your family plan, because a lot of times I think they would have stopped with 4 usable embryos, transferred 1, and then really might have struggled to get enough embryos as she got older to finalize their family. So by talking about future family goals and preparing ourselves for success, we were able to make the best decision for them. Did they want to undergo multiple cycles? No. Was it emotionally, physically, and financially expensive? It was. Even in cases like this, where there's a genetic disease involved, insurance does not cover IVF for most people, which is unfair but a reality in today's medical world. I also think it's important to know right now, there's a lot of people opposed to genetic testing. What would a couple like this do in this circumstance? If they wouldn't be able to do genetic testing, they might be forced to have children who could be very, very sick. Not only is this allowing them control in planning their family, but also helping them have the healthiest kids possible, which I don't know how you can be somebody who's opposed to that. But it highlights that genetic testing is so much more complicated than we give it credit for. And it's so much more than picking the eye color of your baby. Our goal is always a healthy baby, and we're trying to help our patients get to that goal in the way that is best for them. IVF is not a guarantee. It's a medical process. It has a lot of different variables. And one of the most common things that I hear is just that somebody wasn't prepared. They didn't have any expectations set about what the process should look like or what their numbers would be, how many eggs they might get, what their number of embryos would be, or even how many embryos they should have based on their family size. So often, clinics are just pushing patients through cycles, and unfortunately, IVF is often called an industry, meaning there's a business side to a lot of practices that are really large, and they might be backed by people who have other interests than what is best for the patient at their heart. This means it's up to you to advocate for yourself, to find a good clinic, and to ask all the right questions. I hate that that's how medicine is, but that's why this podcast exists, so that you can be as prepared as possible and your best advocate as we go. So that brings us to our last section, which is, how do I equip you for success? How can you be the best advocate for your own IVF cycle? Number one is going to be to ask questions. What is my ovarian reserve? What do we expect for my egg count? How many embryos would you expect this gives me that would be usable based on my age? Based on my family goals, how many cycles would I expect that I would need if everything goes average? Give your doctor the out, meaning you know that it might take more than one cycle, or you understand that cycles may not go perfect, so you're not going to hold them to these answers. Ask them what protocol you're doing and why if they don't tell you. Know if you're going to be doing genetic testing or not. Know if you're planning on a frozen embryo transfer like we went over, or if your clinic is recommending a fresh transfer for some reason. This is all very important information for you to be prepared. And then ask them about the embryo transfer, the protocol, and your clinic success rate so that you can be prepared. I also think there's just some clinic basics. Who will be doing your monitoring? Is it a radiologist or an ultrasound tech, or will your doctor be doing it? At our clinic, for example, the physicians do the monitoring. So you'll always see me or my partner. We think that that's a really important part of the process so that you can get real-time results from a physician that you trust immediately. Who will be doing your egg retrieval? Is it your doctor for sure? Or is it just a doctor at the practice? Or is it a nurse practitioner? You deserve to know who you're going to be seeing on these important timeframes. And similarly, who will be doing your embryo transfer? How do you find out results? In IVF, you're going to your clinic a lot, but how are they communicating back to you? Is it a phone call? If so, are you somebody who answers the phone? Is there a patient portal, or do they email you? You should know what to expect. Similarly, when are the appointments? Is your clinic doing monitoring in the morning? Is it going to take 20 minutes in and out, blood and ultrasound at the same place? Are you going to have to wait a long time? Is it a first come, first serve model? Do you have to go to a separate lab to get your blood drawn? This could take your whole day. I'm a big believer that IVF should not be your whole life. It's just a part of your life, but you don't know what to expect unless you ask the questions. And the last thing I want you to know is that you can prepare physically for the process, and you should. So often I see patients just jump into IVF and not think about putting their best eggs and sperm forward. I want you to take a moment and really prioritize the things that are going to decrease inflammation and set you up for success. This is going to include a diet full of whole foods, healthy fruits, vegetables, healthy fats, proteins, and we're going to stay away from refined carbohydrates, processed foods, added sugar. I want you to get enough sleep at night, at least 7 to 8 hours, and really prioritize setting a good sleep environment. Consider supplements if they're right for you. For most of my patients going through IVF, I recommend CoQ10, 200 milligrams, 3 times a day, so 600 total milligrams, in addition to a prenatal vitamin, vitamin D, and some omega-3 fatty acids. Ask your doctor, though, before you take any supplements, because we don't want to be taking something that could interfere with your cycle. I also want you to move your body. Think about movement as a way for healing, as a way for stress relief, but also remember that building muscle helps improve insulin resistance, and insulin resistance can cause inflammation. And make sure that you're decreasing your stress. which that is so much easier said than done, but carve out some time just for you. Maybe it's journaling, meditation, mindfulness, acupuncture, yoga, a walk outside. What works for you is going to be different than what works for me, and that's okay. I want you to minimize all the things that are toxic in our world. So whether it's plastics in the kitchen, thermal receipts, or smoking cigarettes, marijuana, or alcohol, you deserve to put the best eggs and sperm forward. And we want to make sure that male partner is not exposing his testes to any additional heat, because heat is toxic to sperm. So hot tubs and saunas, they're out for the time being. And then lastly, know what to expect. We can always handle things if we know what the road is going to look like. It's so much harder if the road ahead is completely unknown. So ask questions, be prepared for your timeline. I usually say that from the moment we're going to start the suppression until the moment you get your positive pregnancy test, if we do one cycle of IVF and then an embryo transfer, is usually about 4 months. Most people's jaws drop when I say that number, and I know it's a lot longer than we're expecting. But if you know it's going to be 4 months, you're going to tolerate that so much more than if you think it's just going to be 1 month cycle and be done with it all. So know, based on your protocol and your clinic, how long is this process going to take so that you can prepare the best for it. Well, I hope you understand that IVF is a lot of science, but it's more than that too. It can be a very powerful tool that you can use in building your family and having the healthiest children possible. But in the end, it's a personal decision. But IVF is not the same every place that you go. And it's up to you to find a clinic that you trust, a care team that is advocating for you, and to ask the right questions along the way. IVF can help you be empowered in your family building journey, but it is okay if it's not the right choice for you. But the more you know, and the more you understand, the more empowered you are to make that right decision. Thank you so much for listening to this week's episode of As a Woman. And until next week, thank you, friends. Thank you for listening to the As a Woman podcast. If you're ready to take control of your reproductive health, my new book, The Fertility Formula, is your next step. It's a science-backed guide to understanding your hormones, optimizing your fertility, and owning your reproductive future. You can order your copy and learn more at nataliecrawfordmd.com/book. And as always, follow along at Natalie Crawford MD for even more support. Because knowledge is power, and your health deserves a formula made just for you as a woman.